Okay, good morning, good afternoon, and good evening to everyone. Welcome to ISGyP Live Journal Club Western Hemisphere. Our theme today is Vulvar and Vaginal Pathology, and I'm Becca Walski, one of your co-moderators, speaking to you from the University of Colorado in the USA. I'm joined by my co-moderator, Dr. Ian Hageman, who's joining us from WashU in St. Louis, USA. So please feel free to say hello and let us know where you are in the world in the chat. I mean that I really would love to see where you all are in the world in the chat. Slide advancing. So before we get to our programming, I'll draw your attention to these recent and upcoming ISGyP Live events. All of these can be accessed on our education website, isgyp.ca, and look for the interesting case presentation August 28th. That'll be at 7 a.m. US Eastern Time. And the podcast will drop August 28th as well, with the host, Dr. Kyle Devins, speaking to Dr. Simona Stolniku about cervical squamous cell carcinoma. So you can register for those. Also, importantly, the 4th annual ISGyP fully virtual meeting will be on September 28th. It's essentially running around the clock with various speakers, so something for every time zone. And this is at no cost, so please consider registering. A reminder that ISGyP Journal Club is global, with the Western Hemisphere occurring the third Wednesday of every other month at 12 noon Eastern Time, and the Eastern Hemisphere occurring the third Thursday of the alternating months at 12 noon Melbourne time. Here's the schedule of topics through 2024. In September, the Eastern Hemisphere group will present a journal club on mesenchymal lesions. We do encourage any trainee or early career pathologist with an interest in Gyn path to volunteer to present. You do not need to be a member of ISGyP. We do offer detailed mentorship leading up to these presentations, in particular for this journal club. So if you're at all interested in presenting at either JC or ICP, I would really encourage you to reach out. You can find our emails on the ISGyP website, or they're listed here, and volunteer to present. That's really all you need to do. You just need access to the internet to be able to do this. So I want to let you all know this is my last journal club as co-moderator, and it has been an absolute honor for me to be able to interact with you all for the last 2 years. I'm excited to welcome Dr. Zara Ordulu to take my place as the newest co-moderator for the Western Hemisphere. She is a gynecologic, she's here waving, gynecologic and molecular pathologist. And she recently joined the faculty at Brigham and Women's Hospital in the US. And as you can see, she's joining us here as the panelist. So very excited to welcome Dr. Ordulu. Now, the spotlight to the main event is our 3 volunteer presenters today. We have Dr. Tayler Gant, a third-year resident at Cedars-Sinai in California in the US. Dr. Margaret Fink is a second-year resident at Washington University in St. Louis, USA. And finally, Dr. Kritika Prasai is a fourth-year resident at the U Chicago Endeavor Health / formerly North Shore program near Chicago, Illinois in the US. And I want to thank all of these volunteers for presenting today. The objectives for this journal club include engaging trainees and early career pathologists, offering opportunities for presenting and moderating to members from all parts of the globe, providing mentorship, and engaging future leaders like you all from around the world. Here's the outline and assignment that we offer to each of our 3 presenters. We do also, once we start to engage with a volunteer presenter, we provide a PowerPoint template. So I'm encouraging all of you that tune in month after month to consider presenting as well. So here's the schedule for today. We'll hear from Dr. Gant first, followed by Dr. Fink, and then Dr. Prasai. We're in the webinar format, so let us know where you are in the world in the chat. I see 7 people so far in the chat. And yet there are more people attending. So let us know where you are. Say hi. And then if you have questions, we would welcome them. You can put those into the Q&A, okay? And there's an option to upvote those questions. So now I'll stop sharing my screen, and Dr. Gant, you can please share your screen, and I'll ask and remind the other panelists to mute. Feel free to turn off your cameras as well, and each of you can introduce your article. So I will mute myself here.
All right, can you hear me and see my screen okay? Okay.
Yes.
All right, so I'm Tayler Gant. I'm a third-year pathology resident at Cedars-Sinai in Los Angeles, and I will be presenting our first journal club article today. So I'll be presenting vulvar yolk sac tumors or somatically derived SMARCB1 deficient neoplasms. And this is by David, Kolin, and colleagues. So for introduction, yolk sac tumors are usually derived from germ cells in the ovary or testes, often as a component of a mixed germ cell tumor. They're characterized by a wide range of morphologic patterns, including reticular, microcystic, solid, papillary, glandular, and hepatoid appearances. They're positive for germ cell markers Sol4, as well as more specific yolk sac markers, including glycogan-3 and alpha-fetoprotein. Extragonadal germ cell tumors occur most frequently in the brain, mediastinum, retroperitoneum, and pelvis, and they are particularly rare in the vulva. Most are single case reports, and yolk sac tumor is the most common subtype. So there's multiple theories for the pathogenesis of extragonadal yolk sac tumors that have been proposed, and those include malignant transformation, somatic differentiation of an epithelial malignancy, and metastases from an ovarian tumor. Like other germ cell tumors, yolk sac tumors may harbor an isochrome 12p. And unlike vaginal yolk sac tumors, those reported in the vulva affect middle-aged women, are less responsive to chemotherapy, and associated with a worse prognosis. Local recurrences and metastases, sometimes years following the initial diagnosis, and even death from disease, are common even when patients receive chemotherapy regimens, and are typically successful for treating ovarian germ cell tumors. The molecular features of vulvar yolk sac tumors have not been previously studied. And in the vulva, SMARCB1 deficient neoplasms can include epithelioid sarcoma, myoepithelial carcinoma, and myoepithelioma-like tumors of the vulvar region, and yolk sac morphology in this group of tumors has not yet been described. So the authors hypothesize that vulvar yolk sac tumors are somatically derived and arise from SMARCB1 deficient neoplasms. Onto materials and methods. So case selection of vulvar yolk sac tumors were retrospectively identified using the lab information systems of two institutions, which included Brigham and Women's Hospital and Stanford University Medical Center. Immunohistochemistry for case 1 and 2 was performed on 4 micrometer thick sections of formalin-fixed paraffin-embedded tissue for SMARCB1, as well as the remaining IHC stains listed here. Cases 1 and 2 underwent massively parallel sequencing using the OncoPanel assay at Brigham and Women's Hospital. And the analysis of sequence data was performed using a custom bioinformatics pipeline. FISH was performed with KRAS probe set, which includes a chromosome number 12 centrometric control probe and identifies KRAS copy number as an indicator of chromosome number 12 short arm copy. So for cases and results, there were 3 cases with yolk sac tumor-like morphology that were analyzed, and they showed medium to large epithelioid cells with variably prominent nucleoli. For case number 1, this was a 34-year-old female with a sub-centimeter mass in the labium majus, which was stable in size for 6 months before rapidly growing during pregnancy up to 4.5 centimeters. The patient received 2 cycles of chemotherapy while pregnant, and 3 months later, she developed lung metastases and received a germ cell tumor chemotherapy regimen, then later developed brain metastases and unfortunately died from the disease 2 years after the initial diagnosis. For case number 2, this was a 32-year-old female who presented with a 3.7 centimeter mass on the mons pubis, which came to attention 1 year after an uneventful pregnancy. She received 4 cycles of chemotherapy and had local recurrence in the labium majum and vagina. After tumor sequencing revealed a 2-copy deletion of SMARCB1, the patient received an enhancer of ZEST homolog 2, which is an EZH2 inhibitor. Unfortunately, her disease continued to progress, and she died approximately 1.5 years after her original diagnosis. Her serum AFP was peaked at about 1200 at the time of death. In case number 3, this was a 25-year-old female who presented with a 1.9 centimeter left labial mass, which she had noted to be present for 1 month. The lesion was initially diagnosed as an INI1 deficient malignant epithelioid neoplasm, with a myoepithelial carcinoma being favored. She underwent a resection as well as 3 cycles of chemotherapy. She also developed recurrence and was started on the same EZH2 inhibitor as for case number 2. Her AFP levels peaked at 223, and a follow-up PET scan showed an increased metabolic activity in her inguinal and external iliac lymph nodes, which were then biopsied and diagnosed as metastatic SMARCB1 deficient malignant epithelioid neoplasm with a yolk sac tumor differentiation. Moving on to histology. So here is the H&E for case number 1, and this demonstrated predominantly microcystic and reticular architecture with areas of solid growth, as you can appreciate in parts A through C. And the brain metastases were composed predominantly of solid sheets of poorly differentiated tumor cells, which you can see here in part D. And focally, the metastases showed discohesive epithelioid cells with rhabdoid morphology, similar to proximal type epithelioid carcinoma, which you can see in part E. And this was an appearance that was not appreciated in her primary tumor. For the H&E for case 2, this demonstrated a variety of morphologic patterns, including solid, cystic, microcystic, reticular, glandular, and papillary, as well as structures reminiscent of Schiller-Duval bodies. And for case number 3, this showed a predominant myxoid stroma with microcystic and ribbon-like growth. Focally, the tumor cells formed solid sheets, papillary and micropapillary structures, and occasional Schiller-Duval bodies were present here as well, which you can appreciate in part F. Moving on to immunohistochemistry. So for all 3 of these cases, a loss of SMARCB1 staining was demonstrated. And all 3 cases were positive for SAL4. They were all 3 positive for glypican-3, as well as alpha-fetoprotein. Case number 3 showed focal and patchy positivity for AFP, while case number 1 was negative, and case number 2 showed only rare cells that were staining. Pan-keratin stains were positive in all 3 tumors, and EMA showed patchy multifocal positivity. And as well as the remaining IHC stains, the estrogen receptor, progesterone receptor, S100, GFAP, OCT34, and CD34 were negative in all tested cases. Moving on to the discussion. So after the analysis of these 3 cases, the authors posit that the tumors represent somatically derived tumors with yolk sac-like tumor morphology. The 2 vulvar tumors in this series that underwent genomic profiling did not demonstrate the previously mentioned genetic abnormalities found in gonadal yolk sac tumors, and the 3rd tumor did not harbor the isochrome 12p, which we often see in yolk sac tumors. The loss of 22q and the SMARCB1 locus found in case 2 has not been reported in any gonadal germ cell tumors. And the EMA positivity seen in these two cases in the series would be unusual for gonadal yolk sac tumors, which typically show only focal staining. SAL4 is a marker typically associated with germ cell neoplasia, and this was expressed in all 3 tumors. And the serum AFP is a reliably elevated marker that was elevated in all patients with ovarian yolk sac tumors, but in only about half of patients with vulvar yolk sac tumors, which is further suggesting a different biology between tumors at the 2 sites. One of the cases in the current series occurred during pregnancy, and another developed during the 1st year postpartum. However, because these cases are so rare, it prevents us establishing a definitive link between their development and the concurrent pregnancy. So this may be just purely coincidental. And then for SMARCB1 deficient neoplasms, they're usually estrogen and progesterone receptor negative, which is suggesting that hormones don't play a role in tumor progression. In the 3 tumors presented, there were focal areas which were typical of epithelial sarcoma. In case number 1, it was the brain metastases, and myoepithelial carcinoma, which was for case 3 in the primary tumor. And so these findings suggest that there are multiple pathways that may potentially lead to yolk sac tumor-like morphology. For strengths and limitations, other SMARCB1 deficient neoplasms and vulvar yolk sac tumors were considered unrelated until now. And primary yolk sac tumors of the vulva are very rare and often have an aggressive disease course, which we could appreciate in these 3 unfortunate cases. There have been isolated case reports of responses to immune checkpoint blockade in SMARCB1 deficient and SMARCA4 deficient tumors. And so the identification of these cases is important because of a worse prognosis, their reduced responsiveness to chemotherapy, and the possibility of a targeted therapy with EZH2 and or immune checkpoint inhibitors. So this suggests SMARCB1 immunohistochemistry should be performed on any vulvar, inguinal, or perineal tumor with yolk sac-like morphology to exclude a somatically derived tumor. In practice, the author suggests diagnosing these tumors as SMARCB1 deficient malignant neoplasm with yolk sac tumor-like morphology, and there's additional investigation that's still warranted. And of course, due to the rarity of this entity, the limitation of this study was the small sample size. However, overall, the study of additional cases from the vulva and possibly other extragonadal sites would be helpful to identify if this is a recurrent finding in other extragonadal tumors with yolk sac-like morphology. And it raises the possibility that all yolk sac tumors of the vulva are better classified as morphologic variants of SMARCB1 deficient neoplasms. And I'd like to thank everyone for letting me present today.
Great. It's fantastic. Thank you. If you want to stop sharing your screen, and if any questions come up, we'll take them at the end. So we can move on to Dr. Margaret Fink. If you want to share your screen.
Okay. All right. Can you see and hear me okay?
Yeah.
Okay, great. My name is Margaret Fink. I am a second-year resident at Washington University in St. Louis in anatomic and clinical pathology. And today I'm going to be presenting this article by Melkamu et al., Histopathologic Patterns of Female Genital Tuberculosis with Clinical Correlation, a 10-year retrospective cross-sectional study. So as some background, tuberculosis infections are a lead cause of morbidity and mortality in low and middle income countries. Ethiopia is one such country with a tuberculosis incident rate of 132 per 100,000 people and death rate of 17 per 100,000 people. One common form of extrapulmonary tuberculosis is genitourinary tuberculosis, but the burden of genital tuberculosis is underestimated, as this is a difficult diagnosis to make and patients are often asymptomatic or have symptoms that can be explained by other causes. Female genital tuberculosis, which I'll be abbreviating FGTB, can lead to infertility and other pelvic complications. Ethiopia has a high prevalence of tuberculosis and HIV, and because of COVID-19, services to treat these conditions have been disrupted. And so therefore we can expect an increase in tuberculosis morbidity and mortality. And this study aimed to investigate the trend of FGTB over the past 10 years, as well as investigate the histologic patterns of FGTB in correlation with clinical presentation, with the aim to enhance early diagnosis and management of these patients with FGTB. So this was a retrospective cross-sectional study done at the Department of Pathology in Addis Ababa University in Ethiopia, and included samples from 2013 to August 30, 2022. And this included all cases of FGTB diagnosed on histopathology during this 10-year time period. Inclusion criteria were all cases with this histologic diagnosis, and exclusion criteria were FGTB with incomplete data. The data was collected from medical charts, and 61 tissue blocks were sent for acid-fast bacilli staining. So the histopathologic patterns were determined by staging of granulomas seen on histopathology using a previously described staging system. Stage 1 granulomas consist of irregular clusters of epithelioid cells that are interspersed with lymphocytes, and necrosis is notably absent. Stage 2 granulomas consist of epithelioid cell aggregates with well-defined borders and absent or very small amounts of necrosis. Stage 3 granulomas, similar to Stage 2, consist of epithelioid cell aggregates with well-defined borders, and now there's limited areas of central caseous necrosis. And Stage 4 granulomas are multicentric epithelioid cell clusters with irregular borders and now extensive areas of caseous necrosis. So the results of this study, they identified 122 patients with a histologic diagnosis of FGTB, but 14 were excluded because of incomplete clinical data. So of all the female genital tract specimens, this was just under 1%. 6.5% of the patients identified had HIV co-infection. And interestingly, most of the patients were between ages 20 and 39, with the median age of 29, a mean age of 32.4, 43% were between 20 and 29, 28.7% were between 30 and 39. So the researchers looked at the prevalence of FGTB along each of the years, and they noted overall the prevalence declined, but very slightly. They also looked at the clinical presentation of patients with FGTB, and they found the most common were menstrual disturbance with 46.3%, abdominal pelvic pain with 34.3%, infertility with 32.4%, and abdominal pelvic mass with 29.6%. But there was no overarching single presentation of the patients with FGTB, and it was a varied presentation. And some of the patients had more than one presentation, which is why these do not add up to 100%. Of the patients with menstrual disturbance, 66% of this was amenorrhea and 34% was menometorrhagia. The researchers also looked at the most common procedures to identify FGTB, and the most common procedure to acquire tissue for this assessment was endometrial curettage with 52.8%. They also found that the most common organ involved was the endometrium with 55.6%. The researchers also looked at different granuloma staging in different organs. In the ovary, more patients had stage 3 or 4 with 87.5%. In the fallopian tube, there was also a majority of stage 3 or 4 at 68%. And in the cervix, 87.5% were now stage 1 or 2, 12.5% were stage 3 or 4. And the endometrium was more evenly split, but still more stage 1 or 2, with 53.3% stage 1 or 2, and 46.7% stage 3 or 4. The researchers also looked more into the staging of granulomas in the endometrium and the patient presentations, and they found that of those with stage 3 or 4 granulomas, 6 had regular cycles, 5 were postmenopausal, 13 were amenorrheic, and 4 had menometorrhagia. And those with stage 1 or 2 granulomas, 10 had regular cycles, 1 was postmenopausal, 3 had postmenopausal bleeding, 9 were amenorrheic, and 9 had menometorrhagia. The researchers also looked at acid-fast bacilli staining in these tissues. They found that tissues with stage 1 or 2 granulomas had 35.3% AFB detection, and 51.9% of tissues with stage 3 or 4 granulomas had AFB detection. There was a weak positive correlation via Pearson correlation, but this was not statistically significant. So for the discussion, as I said, they identified 0.94% of the female genital tract specimens had tuberculosis present. And they noted this is a declining annual percentage, but this is a lower than expected proportion of tuberculosis cases compared to other studies. And the researchers explained this could be because other diagnostic methods, such as culture and sensitive molecular techniques, were not used to identify these cases. They also noted that most patients were between ages 20 and 39, and this is consistent with other prior studies. And they explained that this could be caused by an early marriage and pregnancy and a young age of the general population. And therefore, more of this age group could be seeking gynecologic care or fertility evaluation and treatment. This can also be explained by the atrophic endometrium, such as in postmenopausal women, that is inhospitable to mycobacterium development. There was one study that found genital tuberculosis was more common after menopause. They found that most common presentations were menstrual disturbance, pelvic pain, and infertility, and this was also generally consistent with other studies of genital tuberculosis. However, the presentation of FGTB is varied and nonspecific. They also found the endometrium was the most commonly affected organ at 55.6%. Other studies noted that the fallopian tube is the most commonly involved. The researchers explained this could be because when the endometrium is involved, usually it is secondary to fallopian tube involvement. And in this current study, sampling bias might be the cause of overrepresentation of endometrial involvement, as the endometrium is easily accessible for biopsy, and most specimens in this study were endometrial biopsies, with 52.8% being endometrial curettage. They also found 46.7% of endometrial samples showed granulomas with varying levels of caseous necrosis. Another study done by researcher Mondal et al. Showed a much lower rate of caseation. And the researchers explained that caseation is less common in the endometrium during the reproductive period due to routine shedding, so granulomas are more likely stage 1 or 2. But in this study, more caseation could have been accounted for based on the number of amenorrheic and postmenopausal women. The researchers also described that progesterone, interestingly, has a flaring effect on the endometrium, and sampling during the late secretory phase or just before menstruation is ideal. They also noted that acid-fast bacilli were detected in 42.6% of FGT tissues with tuberculosis. And this is also lower than expected based on other studies that were reporting AFB detection of tuberculosis in other anatomic locations. And they explained this could be because of the paucibacillary tendency of FGTB. They noted that AFB was detected in 35.3% of tissues with stage 1 or 2 granulomas and 51.9% of tissues with stage 3 or 4 granulomas. And there was a correlation, but not statistically significant. And so this indicates that acid-fast bacilli detection is not necessarily sufficient to diagnose FGTB, and histopathologic morphology and granuloma grading should be the guiding factor. Some strengths of the study include this was 10 years of retrospective data, and this was a study aimed at examining an important aspect of tuberculosis infection in a country with a high tuberculosis burden, but there's limited studies been done on FGTB. Limitations include the definitive evidence of a mycobacterial tuberculosis infection via PCR or culture was absent because of unavailability. There was some sampling bias, as most specimens were endometrial curettage samples. And I thought it was a retrospective study from 2013 to 2022, which includes pre and post-COVID samples. And the researchers indicated that there was some disturbance in care for tuberculosis and HIV after COVID, and it would be interesting to split this population apart. Also, more explicit data regarding each patient and what specimens were provided could have been incorporated, such as were any patients included twice with 2 different specimens, such as an endometrial curettage and a different biopsy. Some future directions that could be done, a larger study that investigated HIV or immunosuppression levels with histologic features of FGTB might be done, as granulomas can vary in appearance based on the amount of immunosuppression present in a patient. Also, a study could be involved that incorporates investigating if there's the extent of granuloma burden correlates with tuberculosis burden or extent of disease, and further investigation of acid-fast bacilli detection rates in different stages of granulomas could be investigated. Furthermore, I think it'd be interesting to look at clinical presentation compared to the stage of granuloma and/or location of involvement in the female genital tuberculosis patients. And additionally, I think more could be involved in looking at the outcomes of FGTB diagnosis by pathology. So some take-home points for this study FGTB infection was the most commonly presented with varied gynecologic symptoms, including menstrual disturbances, abdominal pelvic pain, and infertility. The endometrium was the most commonly affected organ in the current study, mostly with stage 1 or 2 granulomas. And acid-fast bacilli were found in 42.6% of FGTB cases, indicating that the absence of AFB-positive staining doesn't prove the absence of a tuberculosis infection. These are my references, and thank you very much for your attention.
Okay, thank you, Dr. Fink. That was excellent. So we can have Dr. Prasai is next. If you want to go ahead and share your screen and unmute yourself. Looks good. We just need you to unmute yourself.
All right, can you hear me well and
Yes.
see my screen okay?
Yes.
All right. Okay, so first of all, thank you so much for having me here today. My name is Kritika Prasai. I'm a PGY for APCP resident at University of Chicago North Shore program in Evanston. And today I'll be talking about this paper on cystic carcinoma of vulva and vagina. This study was done at Portuguese Institute of Oncology at Lisbon, Portugal. So before we dive into the paper, I wanted to give a brief background on cystic carcinoma. And for the purpose of this talk, I'll be referring to it as ACC. Okay. Sorry, can you see my screen okay?
Yes, we can.
Okay. All right, so sorry about that. So, this tumor is a rare tumor and is classically seen in the major and minor salivary glands, as well as secretory glands of other locations like lacrimal glands, skin, breast, prostate, and lower female genital tracts. In female genital tracts, ACC has been reported to involve Bartholin glands of vulva and is also thought to arise from the reserved cells of uterine cervix. The tumor is notoriously known to have perineural invasion, frequent mets, high recurrence rate, and hematogenous spread to distant sites. It is composed of uniform basaloid cells arranged in different patterns, including tubular, cribriform, solid, and mostly it presents as a mixture of patterns. The tumor nests form sharply demarcated borders with surrounding hyalinized stroma, and most tumors show perineural invasion. It's a biphasic tumor with ductal and myoepithelial cells that characteristically forms these true and pseudolumens. The ductal cells are present luminally and myoepithelial cells are present abluminally in the true lumen. And the pseudolumens are components of the tumor stroma that are surrounded by the myoepithelial cells. The tumor is positive for the markers of ductal cells like CK7, CAM52, and myoepithelial markers like SMA, S100, P40, and P63, and is also seen to be generally positive for c-KIT, SOX10, and GATA3. So MIB and FIB fusion is considered the genomic hallmark of ACC in the salivary gland and is seen in about 40 to 80% of these cases. Literature also reports that the aberrant expression of MIB is seen in about 60% of all ACCs, and MIBL1 is seen in about 35% of the cases of ACC without the MIB and FIB fusion. MIBL1 belongs to the same gene family as MIB, and it codes for the transcriptional factor that is needed in the cellular differentiation, growth, and survival. In ACC, the tumors with MIBL1 fusion are seen to behave similarly as those with the MIB fusion. So the other molecular alterations that are associated with ACC involve EGFR and NOT signaling, to name a few, and genes of histone modification pathway like ARID1A, KDM6A. ACC of vulva and vagina is extremely rare, and it accounts for less than 1% of the overall genital tract malignancy, and about 10 to 15% of the tumor arising from the Bartholin's gland. It is seen in postmenopausal women presenting with non-specific symptoms like vulvar swelling or mass, and it has been reported to be mistaken for vulvar cyst or abscesses. This tumor is not associated with HPV infection. Most of the studies on ACC are on that of salivary gland, and with very few studies on ACC of the female lower genital tract. This paper expands on the clinical findings, histomorphology, and the molecular findings of ACC arising in vulva and vagina. So it's a retrospective study looking into 5 cases of ACC of vulva and vagina treated between the years 1963 to 2020 at a single institution. The data on age, site and site of tumor, therapeutic approach, tumor recurrence status, and follow-up intervals were collected. FFP blocks were available for 4 cases that were utilized to obtain H&E sections, perform IHC, and FISH study. Block from case number 5 from 1963 wasn't available. So this table from the paper summarizing the clinical and morphologic findings show that the median age of diagnosis was 52 years. The tumor size ranged from 0.5 to 5 centimeters. All patients were treated with surgery, and 2 cases had positive resection margin. Mean follow-up for these patients was 11 years, with relapse seen in 4 out of the 5 cases. And on histology, peritoneal invasion was seen in 4 cases, and the main architectural pattern present was tubular and cribiform. Here is an H&E from one of their cases showing tubular and cribiform pattern. Pseudolimens with basement membrane-like material, hyalinized stroma, as well as peritoneal invasion. So for IHC, CAM52 showed ductal staining in all 4 cases, and staining of the myoepithelial cells was present in 3 cases. And CKS56 was positive in the myoepithelial cells of all 4 cases. So c-KIT was positive, or at least focally positive in all 4 cases, and S100 was focally positive in 3 out of the 4 cases, so was calponin. DOG1 was expressed in the luminal surface of all 4 cases. ER, PR, Paxate, and NKX3.1 was negative in all cases. So for this study, the break-apart probe was used for the individual genes. MIB, MIBL1, and NFib were the genes that was tested. And rearrangement of MIB was identified as seen in this image on the left, with separation of the red and green colored probes, which normally would have been juxtaposed to one another, as seen in the image on the right for MIBL1. So to summarize the molecular findings, MIB rearrangement was seen in 3 out of the 4 cases, of which 1 case showed concurrent MIB amplification. No MIB1 or MIBL1 or NFib rearrangement was present, and no MIB NFib fusion was identified using the fusion probe. So this study recapitulates that ACC of the vulva is present in elderly women. It is associated with high rate of recurrence and peritoneal invasion, also highlighting that despite the disease recurrences and metastasis, the overall survival is generally seen to be not as affected. So with no standardized treatment guidelines in place, wide excision with tumor-free margin is considered the gold standard. All cases in this study underwent surgical resection and radiation therapy upon recurrence of the disease. And radiation has been known to be effective against the ACC of other locations. And we see the similar trend in this study, with 4 out of 5 cases being alive and well without the disease. And one of the cases, meds to lungs, showed good response to combination chemotherapy with local intensity modulated radiation. The paper also reiterates the histomorphology of the tumor and as described in the previous literature, and it highlights the biphasic nature of the tumor through IHC. Additionally, DOG1, which is seen to be expressed in the normal SNR cells and the tumors of salivary gland, including the ACC, was found to be expressed in all 4 cases. ER and PR stains were negative in all 4 cases, unlike some other studies of salivary gland tumor that have shown these stains to be positive. NKX3.1, which is seen to be positive in the benign Bartholin's gland, was negative in the tumor cells of all 4 cases. So this information can be actually used to differentiate ACC from adenoid basal cell carcinoma, which can look similar to ACC if it is arising in the uterine cervix. So in terms of molecular characterization, here is a schematic representation of the MIB and NFib translocation seen in the ACC of salivary gland, where you can see that MIB oncogene located in chromosomal band 6q23, and the red arrowheads show the reported breakpoints. between the exons 8 and 15. And N-Fib gene is located in chromosomal band 9p2223, and the red arrowheads show the reported breakpoint sites for MIB occurring between exon 8 and 12 and include the 3' untranslated region. The fusion resulting in a significant part of MIB here gets fused with a really small part of N-Fib gene. So in this study, none of the 4 cases had the characteristic MIB N-Fib fusion. There were also no N-Fib or MIBL1 rearrangement as has been previously described in literature, but 3 of the 4 cases showed MIB rearrangement, indicating that there might be another fusion partner for MIB that has not yet been described in vulvar ACC. It could also mean that other alterations not examined here could be the main driver mutations. So MIB rearrangement with fusion partners other than N-Fib have been described previously in other tumors, including the ACC of the salivary glands. Fuji et al. Showed 88% of their cases had MIB, MIBL1 or N-Fib gene alterations, and they proposed 6 groups based on this fusion, namely MIB with N-Fib, MIBL1 with N-Fib, and then MIB, MIBL1 and N-Fib with other gene partners, and a separate gene split negative group. The cases that had MIB and MIBL1 gene alteration in this study were associated with MIB and MYC overexpression, and they showed that MYC overexpression was an independent risk factor for disease-free survival. Likewise, other studies on ACC of the salivary glands have been identified with different fusion partners for MIB and N-Fib, although these made up for a very small number of cases. As for the molecular findings in vulvar ACC, Xing et al. In 2017 reported that out of 9 cases, 2 had classic MIB N-Fib fusion, and 6 of their cases showed N-Fib rearrangement without MIB, suggesting the fusion partners to be likely MIBL1, which is like the second most common fusion partner seen in ACC, or a different fusion partner. Recently, Nakamura et al. Also reported no MIB N-Fib fusion in 2 of the cases they reported. Instead, they had their cases had KRAS mutation and KDM6A. Most recently, Feinberg and team looked into 6 vulvar ACC cases where they found the classic fusion in 3 out of 6 cases. And they also found MIBL1 fusion with other fusion partners like EWSR1 or RAD51B. Additionally, they also found that all of their cases had overexpression of MIB despite no rearrangement or amplification of MIB or. So overall, the current literature on ACC of the vulva vagina show that, like in the salivary gland counterpart, this tumor is strongly associated with MIB, MIBL1 or N-Fib rearrangement. The classic MIB N-Fib fusion are seen to be present in a range that approximates to an average of about 30% cases, which is lower than seen in salivary gland. And recently, alternate fusion partners for MIBL1 have been identified. And the cases that don't have this classic, either MIB, MIBL1 or N-Fib gene rearrangement have been seen to be associated with other mutations like KRAS, GNAS, KDM6A, etc. The other thing is MIB overexpression observed by ISC seem to be a common association in these tumors. In terms of strength, this paper provides a good review and adds evidence to the clinical pathologic findings, including the follow-up data going back years to decades. And it provides, an interesting molecular data that shows MIB rearrangement other than MIB and fusion that has not yet been described in the vulvar ACC. In terms of areas of improvement, a study with a bigger sample size could have provided for a more robust molecular data. However, for a rare tumor like this, it tends to become an unavoidable limitation. Also, targeted FISH, although can be an advantage for identification of rearrangement like we see in this study, it cannot identify other potential alterations that may have been present. Another thing is that the FISH probes are limited by the region of their coverage and cannot identify rearrangements if the breakpoint occur outside of the range. And a more comprehensive test like next-gen sequencing is needed to identify a specific gene alteration. Here, the samples were as old as 25 to 30 years, making sequencing study a challenge in terms of result reliability and cost effectiveness of running these tests. This study serves to expand on the molecular characterization of ACC of vulva and vagina that may be useful in developing targeted molecular therapy, establishing prognostic significance, and a lot more. So these are my references. Thank you so much. And I'm happy to take any questions.
Great. Thank you so much. Thank you for that discussion. That was excellent.
Okay.
There we go. Keep some hand clapping, some kudos. We don't have any Q&A from the audience, no questions. One thing we can ask Dr. Fink, I think we had discussed this briefly in our Zoom discussion before this live event. But what was the process or understanding of the patient's diagnoses of tuberculosis for this study? Did the patients come to the study with the diagnosis of tuberculosis, or were these sites the index sites? Did they expand on that?
So I think that I think they had kind of varied presentation. I think they didn't know specifically they had tuberculosis, and then the diagnosis was made histologically for the specimens.
Okay. Yeah, I wasn't sure if they said explicitly. Did they say explicitly that the diagnosis was unknown and then made on these specimens, or is it possible that they came, with a known diagnosis?
I'm actually not sure myself. I'd have to go back and look, but it sounds like yeah, most of the diagnosis, at least for the specimens they identified, was just made histologically.
Wanted to ask Dr. Gant for a sort of a clarifying question. So in your study of yolk sac tumors, the investigators did show KRAS fish. Do you, after reading this paper, do you think KRAS fish has a role in routine diagnosis of vulvar yolk sac tumors?
It wasn't really one of the major points that I gathered from the article, actually, in terms of diagnosis. I think a lot of it was more on the IHC heavily, and then of course the SMARCB1 too. But yeah, I would say no, it was a part of it, but I don't know if that would become part of the routine.
Yeah, no, I agree with you. It was used as a more of a technique to investigate the sort of somatic versus germ cell nature of the tumors, but I wouldn't want our audience to start validating KRAS fish for use in diagnosis of these tumors when they see them, which of course are pretty rare. So great. Yeah, I agree with you completely.
We do have a question in the Q&A from someone in the audience. Are the yolk sac tumors, do they have a common morphology with other SMARCB1/INI deficient tumors?
Yeah, so from what I gathered, some of the SMARCB1 deficient vulvar neoplasms are like epithelioid sarcoma and myoepithelial carcinoma. And so there was a couple cases, I believe case 1 and case 3 showed sort of resembling that type of architecture and morphology that sort of tied in the argument that it could be possibly somatically derived as well. So I would say in these 3 cases that they presented, there was some overlap in that area, but they also had yolk sac tumor morphology as well.
Okay. I don't see any other questions. I myself don't have any other questions. Any other panelists or presenters have questions? All right.
I was able to look back briefly, and it looks like they didn't really specify what the patients actually came in presenting with. That they just said they diagnosed it histopathologically.
All right. I want to thank you all so much for volunteering to present today. You all did excellent. And anyone out there in the audience, if you want to volunteer to present in the future, please do so. And thanks for joining us.
Right. Bye, everyone.
Bye-bye.
Bye-bye.
Bye. Thank you.
Bye. Thank you.
Don't forget to register and tune in to the annual meeting.